Good morning, everybody. Can you hear me well?
Yes, we can hear you and hear your presentation.
All right. Good morning, everyone. This is Ahmed Hebishy. I'm a second-year resident of internal medicine at ECU Health Medical Center. I also has a background of internal medicine and hem-onc back in Egypt before coming in, and I'm truly interested in giving you and introducing you guys to one of the most interesting cases in the US. So today we will do the story of a teenager who, despite initial confusion of being a cholecystitis case and getting introduced to surgery and stuff like this, she was finally ultimately diagnosed with a Castleman's disease. This actually sheds a light on the importance of history, exam, and histopathology in our arsenal of diagnosis. So picture this, a 19-year-old lady, like ready to go into her third decade of life. Her past medical history is as vibrant as her age. She never had any medical problems, never visited a doctor for like anything other than the regular follow-up and the annual physical exams and stuff like that. And then she enters the medical field in a sort of enigma. So the tale begins with 2 months of nausea, vomiting, and diarrhea associated with abdominal pain. She was referred to her PCP, who found his clue in like kind of a gallbladder stone. So giving the diagnosis of acute calcular cholecystitis, or let's say calcular cholecystitis because it lasted for like more than 2 months. He referred her to surgery. She had surgical intervention. However, this was only the beginning. Everything didn't go as expected. So the unexpected turn after surgery was marked by abdominal swelling, rapid weight gain, persistent abdominal pain, and persistent fluid oozing as well from the site of the surgery. Like she kept oozing serous fluid from the site of the laparoscopy. Patient getting worse and worse, gaining weight, bilateral lower limb edema, puffiness in the eyelids, and there is kind of purple discoloration on the upper eyelids as well. So we saw this patient in the first encounter. She looked really fatigued, and on exam, she had kind of bilateral grade 3 to 4 lower limb edema and reaching up to the abdominal wall with massive ascites appreciated on exam as well. So sure enough, we get some imaging and labs on her, finding out that she had kind of hemoglobin of 8.6 with elevated CRP that was 22, generalized anasarca in the abdomen, and pleural fluid as well. So let's see here, as you see the red arrows in the on the right showing this massive ascites with hepatosplenomegaly. I'm also pointing to it with the arrow, with the black arrow as well. So sure enough, we considered amyloidosis to be like the first like on top of the list of the differential diagnosis, given that the patient had this kind of generalized anasarca out of nowhere, her age category, and also the violaceous color on the upper eyelids that looked exactly like kind of raccoon eyes as well. So we went ahead and got the labs for that, but didn't show that the kappa lambda ratio was like a fancy result. Also, there is no M protein in the serum or urine protein electrophoresis. There is some polyclonal gammopathy, but it's not like monoclonal either on immune fixation as well. So again, on revising this CT images, you can see this the CT chest. There is a red arrow measuring a lymph node that is 12.7. This actually was the first spark in diagnosing Castleman's disease on her. We had a fabulous radiologist that when revising this image, he said, this fits into either amyloidosis or Castleman's disease. So excluding amyloidosis, we left behind with the Castleman disease. So we tried to prove this, and given the criteria of diagnosis weren't like exactly fitting her if we took the NCCN criteria versus the CDCN criteria. So we started consulting hematology on her, and we got this lymph node biopsy showing this kind of germinal center regression with onion peeling. The germinal center regression is like the asterisk sign here in the middle, and then there is like marginal, mantle zone expansion concentric around it, which looks like the onion peels. This is actually very characteristic for Castleman's disease. So we went ahead and did the HHV-8 virus, which was negative. What is Castleman disease? Castleman disease is a group of heterogeneous non-malignant lymphoproliferative disorders. The incidence is exceedingly rare. It's 15 to 19 cases per million in the unicentric type, and it's 5 to 6 cases per million in the multicentric type. When you find any patient with a multicentric disease, you have to further classify this patient according to the presence or absence of the HHV number 8. So 50% of patients will have negative HHV 8 infection, which is kind of preferable prognosis other than the HHV positive. Surprisingly enough, the median age of presentation is around 34 years for the unicentric, and 48 years in the multicentric. So what was interesting about our patient is diagnosis of that kind of multicentric Castleman's disease at the age of only 19, which she just turned in. The clinical presentation is has a wide array of presentation, either asymptomatic, so there is like around 6 to 12% patients that will be incidentally discovered to have these kind of lymph node fitting into the Castleman's disease in radiology made for other reason, but it can be devastating enough to threaten the life as well. Again, we are here with lymph node biopsy, and this is the HHV negative block as well. And after diagnosing the Castleman's disease, it does not only stop at this point. You have to interact the puzzle as well to solve the puzzle about, is it like kind of a bigger syndrome or not? So the bigger syndromes that are, let's say the subvariants of the Castleman's disease that can be associated in some patients is the Tafro syndrome and the Boehm syndrome. Tafro stands for thrombocytopenia, fibrosis, and organomegaly. And then the Boehm syndrome stands for the polyendocrinopathy, organomegaly, and stroke-like presentations. So we went ahead and did the bone marrow aspirate as well, so that we can exclude if the patient has any of these stuff. So it was completely excluded after doing this kind of bone marrow and after consulting a Castleman disease specialist as well nearby in Charlotte. Bottom line, we had this lady, 19-year-old, with generalized anasarca, kind of what we call sometimes the vascular leak syndrome. In this condition, we just wanted to emphasize on the rule of good history, clinical exam, and histopathology in the arena of diagnostic tools. We also wanted to emphasize that you have to keep Castleman disease in mind, especially in patients with unexplained significant anacerca, no matter what the age is. The good news is the patient had received siltoximab Q3 weeks, and after the third dose, I met this patient down around the outpatient clinic, and I didn't even recognize her. She looked so much different. She was doing great, and the response was marvelous. At the end, I want to thank some of my colleagues that helped me doing this, Dr. Josh Zweigel, Dr. Wiles, and all the medical students that saw this patient with me and took care of her. And specifically want to thank Dr. Abdelmanem Ahmed. He's one of the most talented hematologists I ever saw. And he taught me everything I know about hematology back in Egypt. Thank you so much.
Alrighty, thank you so much, Ahmed. I have a question. So siltuximab, what does it target, and how does it contribute to making these patients better?
We found that interleukin-6 actually plays a very important role in the situation of Castleman's disease, either the HHV positive or negative, but specifically in the HHV negative ones, like our patient here, it has a big role causing this kind of cytokine storm and vascular leak syndrome. And we found that the recent guidelines recommended siltuximab as an interleukin 6, which acts on the interleukin 6 as an antagonizing its effect, to be very efficient in these patients. And I actually never used it before. We didn't have this tool previously in where I worked in, but seeing the results now and comparing it to the patients that I saw before, it's actually, there is a very big difference. So the main target is the interleukin-6 for this medication.
Mm-hmm. And what's the value in testing for HHV-8? Does it change the clinical course?
It does change the management. So in the HHV, you have to know what kind of multicentric disease you're dealing with. Then if you had this kind of HHV negative, it's okay to start with siltuximab as a single agent. But if it's positive, probably you will add prednisone on it, or you can also start with rituximab instead, in addition to prednisone. So it changes the medication decision, and also you can expect like more aggressive course with the HHV positive patients.
Mm-hmm. Alrighty, very good. Is there any other questions out in the audience? Alrighty, thank you, Ahmed.